Good afternoon, everybody. We'll get started here in a few moments. Attendance is still a bit low, so I'm sure everyone is just now joining, so we'll give them all a few minutes. If you are a committee member, if you would put your name in the chat. If you are a committee member on the phone, please unmute and let us know that you are here. Again, for those of you who are just now joining us, we are waiting for some more committee members. We should start here in just a few minutes. If you are a committee member, please let us know that you are here by putting your name in the chat. If you are a committee member who is on the phone, please unmute yourself so that we can take good attendance. Thank you. We should be getting started here in just a few minutes.
Hey, everybody. Matthew Hales, Michael Hales, are you on?
He's not just I happen to know that he's traveling to St. George with his kids.
Inside information, yes. I was just going to say my computer is feeling a little glitchy, so if I have to restart it, somebody else can step in, or I'll just have to hop back on, but hopefully it's okay. Can you all hear me okay?
We can.
Okay, well, I'll just see how it goes. Okay, well, Sharon, how are we on forum?
I am still counting. I think everybody kind of joined right at the same time. So just give me another moment or two and we'll let a few more join as well.
No problem.
Has the agenda changed at all, Jesse?
I don't think so.
Okay.
Not that I've seen.
Jesse, the only thing I would just mention is Nate ended up with a conflict. Nate Checkers ended up with a conflict. So Nate Winters and I believe Sherry Watkins, if she is on, I don't think I see her on yet, but they will be covering the DOH DHS joint budget.
Great.
Is there any? I can't see the whole agenda. Is anyone gonna address the Medicaid Director?
I can cover that.
Awesome. Thanks, Emma.
Okay. Well, and just a reminder, if you're a member, a MAC member of the committee, just to put your name in the chat, which you did not do. Okay. Well, we could probably get started, and then Sharon, just let me know when you think we've reached a quorum.
I will let you know because I think we are still a little short today. So, but I will let you know. Thanks, Jesse.
Okay. Yeah, sounds good. Well, the year-end, final end of the year MAC meeting. Don't really understand what happened to 2021, but here we are. Hope everybody is doing well, staying warm and safe. I'm Jessie Mandel. I'm the chair of the MAC and with the organization Voices for Utah Children. I just want to quickly make an announcement that we've determined to continue to hold these meetings virtually, and we'll do so until notice. So If you need any accommodations or have any questions about that, please feel free to reach out to me, but these are virtual notice meetings until further notice. Second, we have some people leaving the MAC, which is wonderful and happy for them, I hope, but we will miss you. Adam Cohen, thank you so much for being on the MAC for all these years. It's been wonderful to work with you, and you're definitely going to be missed. So please drop in and see us anytime.
I will.
All right.
Yeah, thanks, Adam.
Been an honor to serve.
Thanks. And I think you so that's an open seat. It's an open seat that is now we're accepting nominations for. And I think the way that we've structured the bylaws, you were kind of in the seat for the business community, but it's pretty open at this point. So we are welcoming any consumer or people with lived experience, people to fill that seat. If I have that correct. Michael Hales is not here to correct me on the bylaws, so I think we've got that. And I think that, so if you have any nominations, please send them to Sharon. Thanks. And next up, another change. Again, happy for the people who are, to where the change is going, but we will be really missing Emma Chacon. This is your last MAC, which is just unbelievable, and we are so grateful for your many years of service. Stephanie Burdick, are you on the call?
Yes, I am.
Do you want to present the letter?
Sure. Emma, we wrote you a letter, so we're going to read it to you. Dear Emma Chacon, we are writing on behalf of the Medical Care Advisory Committee the letter of appreciation and congratulations for your well-earned retirement after several decades of service. From assisting in work on changing and expanding Medicaid to improving programming with school-based health to the current agency merger, we appreciate that you've been a voice of reason and integrity throughout it all. We appreciate your collaborative style with all the stakeholders and are particularly thankful for the work you've done to ensure consumers' voices are respected and acknowledged. Throughout seasons of change and chaos, your calm and steady leadership has been reassuring. We hope you can look at your work with a peaceful feeling, knowing that you have served Utahns who face so much adversity and are deserving of public servants with your level of character. While there are so many different career paths you could have taken, we thank you for choosing the one you did and for all the contributions you have given to our state. Take care, enjoy retirement, and have a happy and restful 2022.
Well, thank you. So I will just say it has been a long time, 45 years, and I really appreciate it. Thank you.
No, thanks for your service, Emma. Serious.
Emma. We feel
Thank
really
you, Emma.
with you. Thanks.
I'm going to miss you, but I'm happy for you at the same time.
Emma,
Well,
you can always drop in and see us too.
Well, the good thing is that we have a new Medicaid director. The other thing is that I'm actually sort of retiring for the second time and then actually coming back for a short period of time on a part-time basis to actually help with the transition. So I won't be totally gone, and I'm sure I'm going to be, tuning into the MAC because I will still always have an interest. So I'm not entirely gone, but thank you. So maybe is now a good time, Jesse? Do you want me to speak about the?
Yeah, I think so.
Medicaid director. So yeah, I mean, we are really excited about the new Medicaid director. And let's see, I think everyone probably saw the announcement today, hopefully from Governor Cox. So Jack, and I'll probably really ruin my pronunciation.
I'm waiting for this one. Yeah.
Okay, Shepanowski, who is actually coming to us from the state of Texas and has been working for Humana for quite a number of years and has worked for other companies as well. But all of his history, for the most part, his work history has been involved in Medicaid and Medicare programs. He is very familiar with issues like 340B, He actually was one of the leads on the integrated program in the state of Texas called North Star. He's run a behavioral health plan in the past. He is originally from Chicago, has a law degree from Texas A&M, and just seems to be a very engaging and knowledgeable individual. And I mean, we're really excited to have him on board. So he will be here mid-January, around the 10th, and still has to go through Senate confirmation. But in the meantime, the governor has basically appointed Tanya Hales as the interim Medicaid Director during the period in between. And so that's pretty much what I have right now, unless anyone has any questions.
Well, thank you. I had missed that announcement today, so thank you for sharing that. That's and also congratulations, Tanya, for stepping in. Thank you for stepping in while he gets up to speed. And Emma, we're glad that you'll be around a little bit longer.
I'll be working in the background. So.
Well, that's great. That's really exciting news, and we look forward to meeting him. And yeah. Will he be moving to Utah? I assume so.
Yes, it's, I mean, we sort of joked and said, why Utah? And oddly enough, he said that he and his wife actually got married in Utah, and most of her family lives in Montana. So they're ready to come out west. And apparently she has been very involved in community programs in the Dallas area around the homeless in Dallas. And so very much focused on, wanting to be involved in programs and things that make a difference. So I think he'll be a good addition.
Wow, that's great. Well, thank you so much. That's terrific to know. And
Jesse, we'll look forward to introducing him during the next MAC. So.
Right. Yeah. And thanks, Tanya. I was going to mention that because he will be so new, Tanya will help with the next MAC, and then hopefully we'll get Jack into the swing of things in time for February. So
that sounds, yeah, starting right as the session gets underway.
I know, right? That'll be fun.
Well, great. Thank you for that. And yeah, congratulations again. So, okay, and the last thing, one other thing that I'm going to just quickly make sure we approve the minutes from November. I don't know if any members have any changes or edits, but if you want to make any edits or just make a motion to approve them, please do so now.
I read them. This is Brian. I can move approval.
Awesome. Thank you, Brian. Okay. Anybody to second the motion?
I'll second, Jesse.
Thanks. Okay, the minutes are approved, and on we go. I do just want to make sure we have a few minutes for this agenda item, our second agenda item around committee member updates. I know we have a pretty packed agenda, but have really appreciated having this as a standing part of our agenda for any updates, questions, things to flag, events coming. It's just a space to recognize the expertise of our committee members and lift up any questions that maybe you've been dealing with in your work with different Medicaid members. So are there any committee member updates, questions, or concerns? Okay.
I'll throw a link in the chat. It's just a webinar. Some of you might already have the link, but it's a webinar on vaccine confidence training, and it's from an organization that's had some, some successful outcomes. And so for those of you that work in healthcare, if you want to just share it with those within your organizations that are working in trying to improve our vaccination rates for Medicaid members. This organization has had success, particularly around Medicaid members, Medicaid adjacent communities. So I will share that link.
Thank you. And you know, this might be in the director's report, but I'm really excited to learn at the Utah Oral Health Coalition that Medicaid is going to be reimbursing for silver diamide fluoride now, which is for children, which is a procedure that makes it easier for kids to access preventive care. So a lot of the programs that do offer in-school-based dental care for kids will be using this, and others around the state. So it's a really exciting step for kids' dental care. So that was something I just wanted to share too. Great. All right. Thanks, Stacy, for that too. All right, well, let's move on to Nate Winters and Sherry Watkins to talk about the joint budget.
Yeah, and maybe I could just kind of introduce this for a minute, and then I'll turn it over to Nate Winters, because we didn't know Nate Checketts had a conflict until yesterday. You know how Nate's schedule is. So poor Nate Winters, we're kind of putting him on the spot a bit. But essentially this year, and I think we mentioned this before, as we move into the consolidated, new department, we're actually taking steps to act as a consolidated department, now. And so this past process, we actually, both Department of Health and Department of Human Services submitted their appropriations requests up to our normal channels, and then the two departments got together and said we're going to submit a joint request in terms of our request for any adjustments to the 2022 budget, and then also any appropriations requests for the 2023 budget. And then just, what was it, last week, maybe, about a week and a half ago, the governor's budget was released. So Nate's going to basically just talk a little bit about what ended up in the governor's budget for Health and Human Services, which I think we all feel like we actually did pretty well from the executive branch. And then how the Social Services Appropriations committees are also now going to be scheduled around basically the new line items that will be going into place for the Department of Health and Human Services. So Nate, I'm just going to, with that, turn it over to you.
All right, thanks, Emma. And I think I'm flying a little bit solo here today. Actually, I
think you are.
I don't see Sherry on the line either. So Eric, I might lean on you a little bit for some of the Medicaid items and some of our GOPB friends who are on the call as well. Just by way of quick introduction, I'm Nate Winters. I'm an Assistant Deputy Director with the Department of Human Services. I've worked for the state for about 10 years, largely in human services, in various kind of divisions and positions over the time. And then as we come together under the merger, I'll be a Deputy Director over our operations section, which will have, our finance and administrative and, other administrative type functions. So quick introduction about me. I see there's 40 minutes scheduled on the agenda. I think we can make up some of that time because I'll be fairly brief. As Emma mentioned, I think when I logged onto this call, I found out that I was the one kind of leading this discussion. So I will do my best to work us through it. So again,
it's a fun position to be in,
it's all right. This is just how we roll. So
thank you.
So I'm just going to kind of run through some of the items in the governor's budget in no particular order, just in a way that I had tracked them as part of my personal process on this. So obviously, Medicaid consensus we see was funded. I think everyone on this call is pretty familiar with that process. I know working with Eric and GOPB, I feel like we all kind of came together and had a good process for what was included in that this year. The funding, so FY 2023 one time, $25 million, and then ongoing in FY 2023 is about $68 million. That was included in the governor's budget. The next item I'll kind of touch on is the Dspd mandated additional needs / youth aging out of juvenile justice and child welfare was fully funded for the amount of about $6.7 million with a one-time back out. And the one-time back out on that is for adjusting for the kids that we know about that are coming in through DCFS and JJS that will only have partial years. The next item on my list was the ongoing maintenance and operations for PRISM. So we know PRISM will go live in January of 2023. And so as that goes live, there's now, required operations and maintenance costs associated with running the system. So that was funded with an amount of about 1.9 million ongoing, with some one-time costs that are associated with the startup of getting that up and going next year.
And Nate, maybe I could just add to that. The reason why we have the one-time appropriation is because CMS, they will pay for running the system at an enhanced rate, but they will only do that after it goes through full certification, which takes about a year to get a system certified. So what they do is they actually drop their federal match rate for that year. So we have to basically have enough funds to pay the additional state share during that year. And then when the system gets certified, they will give us the higher match rate back to the, so we'll be able to give that money back to the general fund, and we'll only need to essentially borrow it for that period. And then we'll be giving that 1.6 million essentially back to the general fund. So.
Perfect. And definitely anyone on the call, feel free to weigh in on some of these. And if you have questions, you can stop me while I'm going. Just, jump in or raise your hand and we'll answer them. The next one on the list, maybe Eric could speak to a little bit, but it's the 12-month eligibility for Medicaid. I believe it's for kids ages 0 to 18. And it's ensuring a 12-month eligibility period for those kids. I don't know, Eric or Emma, if you want to weigh in more on that.
Yeah, maybe I'll just jump in. This actually came from one of the governor's One Utah Roadmap committees. And so, for years, and I know this one's near and dear to Jesse's heart. This one, for many years, we've had periodically this issue come up, but this was actually a recommendation that came from that process, and so that did end up in the governor's budget this year. So this essentially would make Medicaid like CHIP, where even if a child's family's income or circumstances change during that year, they still get a guaranteed 12 months of eligibility, which will be good because it will reduce that churn that happens and will give more continuity of care for kids.
Perfect. I'm not sure if I have this next one labeled correctly, so this is maybe another Emma or Tanya or Eric one. I think it's the Center for Sustainable Healthcare. I think it's another one of the governor's initiatives around the value-based care. Am I right?
Yeah, so you're correct. Again, this is I believe the governor and Rich Saunders did a conference on this, a press conference on this not too long ago. This is to basically create kind of like a think tank, essentially, that would involve public sector and private sector entities to truly try to figure out a way of controlling healthcare and improving quality of healthcare at the same time. I mean, we've been talking about this for years. It almost seems like decades, but really trying to get all the players together to try to do something. If, at least in the state of Utah, we're hoping we can make some meaningful impact. So that's what that is.
Perfect. And so that's, some money in FY22, current year, 650,000. About 1.5 million one time next year with an ongoing amount of about $1 million. So that's that. The next one is Consolidated Appropriation for Loan Repayment Programs. So this is a program, and again, those that were involved can feel free to weigh in, but it's a loan repayment program. I think runs through the rural health program that'll pay back student loans for mental health or other medical professionals. I think it's expanding existing funds that we had, and was another one that I believe was included as part of the governor's roadmap initiative, but also requested by DSAMH and the Department of Health together. And that's funded at about it's funded at $1.7 million in the governor's budget. The next one is the Dspd waiting list. So they requested funds to bring in, I believe it was 328 individuals off the Dspd waiting list, as well as funds for additional staff to help process that. So one of the things we know as we've been bringing more folks in and working with the increasing, populations on the wait list is that we need additional staff to help manage the process to make sure that we're providing better services. So the governor included the funds to bring the individuals in off the waiting list. plus some funding for a couple FTE for Dspd. The next one I have on the list is local health department performance standards for $2 million. This is an item working with the local health departments, and transparency, maybe someone from the health department could weigh in on this. I haven't been as involved in this one, but I know it's providing some additional general funds for our local health departments in a lot of the work that they do with them.
Yeah, sorry, Nate, that's not one that Medicaid folks are very close to. So
if this group doesn't need to know, we'll move on. So the next one, and if it's not beneficial for me to run through all these, I mean, we can kind of focus in on some of the more Medicaid related ones. But Ome Caseload Growth, I think we've seen this one over the years as we've seen the population in Utah is continuing to boom, which is creating additional pressures and demands on the medical examiner's office. They've got funding for about 5 FTE in the governor's budget for this process, which is a great thing for them. The next one I'll jump to, I saw some of the youth providers on here. This would be a good one to cover. Combined, well, actually I'll jump to this, the provider rate increase. So just like the rest of the world, with the providers on the human services side, particularly for our youth residential or family-based care providers, there's just been tremendous pressure placed on them with increasing requirements and demands, but not necessarily increased funding. So we received some funding to help increase our provider rates, our rates to providers, which a couple years ago, this is a long history that you may or may not be interested in, but the legislature actually asked us to do a study on where we're paying our providers. We got some information back that we're paying them significantly less than what we should be paying them. So this is an attempt to help, bring up the rates with our providers who are providing, residential and family-based care for youth in custody. Yeah, so that's that one. Another one is, I think we've seen a lot, and you've probably seen some media stories related to staff recruitment and retention at the State Hospital and Developmental Center. So there's some funding in there to help increase the wages of our psych techs and developmentalists, along with some of our other, kind of entry-level staff at the State Hospital and Developmental Center. And so there's some funding for those institutions' salary rate increases. Utah's Emergency Medical Services and Data System. This is the EMS system that has received some grants over time from the Department of Public Safety. The grants are kind of drying up, and so we need some ongoing costs to continue to maintain the program and system itself, as well as some one-time costs for system enhancements. Oh, go ahead.
Oh, I was going to say, no, you're getting to it. The Hcbs provider rate increases. Yep. Yeah. So.
Okay, so we'll jump to that because that's really what you guys probably want to know. Home and community-based provider wage increases. So the home and community-based providers are currently received a 5% increase, 5% rate increase that's been funded by the ARPA, additional ARPA money that's coming in through Medicaid and the home and community-based services programs. The governor included in his budget to fully fund that 5% going forward, so that we're not creating a structural imbalance with this funds. And making sure that these commitments we've made using the one-time dollars will be continued going forward. There's also an additional 1.5% above that 1% for home and community-based service providers to increase rates an additional 1.5%. So that is in there. I'm trying to think if there's anything necessarily impacting this group.
Yeah, maybe Nate, and I don't recall. Because there's a lot on here. That's why I said I think we actually did pretty well in the governor's budget as a joint department. So I'll just maybe go to a couple of them. The long-term services and supports for behaviorally complex individuals. I think this group has heard us discuss before how we're seeing more and more individuals that have complicated behavioral issues. Some they may have an IDD, they may have chronic medical conditions. They are individuals that need more intensive services. Oftentimes, and because those intensive services really don't exist in our community, the way they really need to be at this point. We've all struggled with how to provide services around these individuals, and it's kids and it's adults, and you know, especially right now with the staffing shortages everywhere, that's making things even more complicated. So we actually have been in collaboration with the Division of Substance Abuse and Mental Health and one entity that basically owns nursing facilities to talk about, you know, could we create a specialized nursing facility or a large wing of a large specialized wing in a nursing facility to be able to provide these services to these individuals, because sometimes they literally need one-on-one, you know, support 24/7. And the other part of this request was to also be able to provide some services in the community as well, so that, you know, folks had somewhere to go as they transition out of a nursing facility. And so this portion of the request represents actually providing support to about potentially 50 individuals in a nursing facility, and trying to bring a program like that up, with the idea that if we can successfully do that and at least take the first step, then perhaps maybe that could be expanded later on to provide more services in the community. So we were just excited to see this on the list, because we have tried to get something like this approved in the past, and we have not been able to do that. The other item on here is Medicaid dental benefit changes for children and pregnant women. Jesse mentioned, you know, the silver diamine fluoride that we're now going to be covering for kids. But in addition to this, you know, we continue in the Medicaid program to really only support, for the most part, if someone gets a crown on a tooth. For the most part, it's a silver crown. We don't do porcelain crowns because of the cost. And also, the Medicaid program continues to pay for basically amalgam, or the metal fillings in teeth, as opposed to the composite white fillings in teeth, again, because of the cost. And this will allow us to, if this is approved by the legislature, it will allow us to then provide those services to pregnant women and children. For individuals who are over 65 or disabled, you are, I'm sure, aware that the University of Utah School of Dentistry is collaborating with us to provide services for those populations, and they are seeding the state share of that benefit for our program. And they have already said they're willing to step up and pay for the cost for those populations to be able to provide porcelain crowns and you know, the white, you know, natural tooth colored fillings, the composite fillings. So we were excited to see this on the list as well, because we have also tried to get this approved for several years, and we were happy to see it in the governor's budget. I think the other one that's probably of key interest to this group is the Dspd caregiver compensation. And Tanya, if you could chime in here if I get this wrong, but again, you're all aware that the funds to be able to do that were basically ended, were one-time funds that ended the end of June. Dspd was able to cobble together some carry forward money to continue those services till the end of December. We have requested approval from CMS to use the ARPA funding, the Medicaid portion of the ARPA funding for these services. CMS has basically declined that request, so that has now been escalated to the governor, who has reached out to the Secretary of Health and Human Services on the federal side. But this would again continue those services if this appropriation is approved. So Tanya, I don't know if you want to say anything else about that piece.
Yeah, no, Emma, I think you nailed it all, and maybe Nate, you may have a little more insight to this too, but I think there has been an additional extension of the funds, if I'm not mistaken. Is that correct?
Yeah, so I think they sent out, I believe they sent out notice that it'd be extended through June.
Okay,
as we
good.
work with our legislative partners, again, using some internal funding from Dspd. I believe that went out.
Yeah, I think it did.
And then we'll work obviously with our legislative partners on, you know, the funding for you know, the future years. So.
Okay, that's great. Thank you. As I'm looking at the list, I think those are probably some of the highlights really in terms of the issues that this group would be most interested in. I think if you have any questions about any of the recommendations in the governor's budget, again, keeping in mind that now we have to go through the legislative process, because in fact, it's the legislature that has authority to appropriate. So they can choose to move forward on these, they can choose to not, or to substitute their own priorities in terms of the appropriations process. So are there any questions about any of these items, or?
But Emma, I think I have my hand raised and so does Steph. So
Oh, okay, sorry, I should actually look at that.
no, that's okay. We could just talk to.
Sure.
But if anybody else has questions, please, throw them in the chat or raise your hand. So I guess two questions I had. One was just, you kind of started to touch on this, but are there any funds where we could be using ARPA funds or other, is everything going through the legislature, or are there any funds that maybe are already dedicated, or there's existing funding streams that could be just direct, using ARPA funds already? So I guess I'm wondering if there are any places where the legislature, where it won't have to all go through the legislature.
Well, I think the reality is that, so there are a couple of pots of ARPA funds, right? The ARPA funds we usually talk about in this meeting is the provision in ARPA that created that initiated a 10% increase in the federal match, which then creates some savings of state dollars, and if approved by CMS, allows us to use those state dollars that have been saved to either match again and draw down federal dollars. And that's what we're using for these supplemental payments that are going to providers, really, for the most part, to help them try to address the workforce shortage and other, just creating or I guess building up or supporting the infrastructure for Hcbs services and for behavioral health services and school-based services. And then there are some areas where CMS has said, that's not matchable with federal funds, but it is consistent with the purpose of ARPA, so you can use your state funds. This is a weird situation where CMS is basically telling us what we can use our state funds for, but that is what we have. So some of it, we're just using state funds to cover some of our spending plan. And then there are some areas where, like I said, with the family caregiver compensation, where CMS has basically declined our request to use federal funds, and we're challenging them on that because we think they're wrong. So that's on the Medicaid ARPA fund piece. And then there are still ARPA funds that were appropriated in that bill that have nothing to do with Medicaid. And some of those are addressed in the governor's budget, and the rest, the governor, from what I understand, said, there's about $100 million out there that I am not going to address, essentially, but the legislature can appropriate. So I think any of that still needs to go through some sort of legislative appropriation. And even the Medicaid ARPA spending plan, we are still, although technically the legislature doesn't have to vote on that appropriation, we are still making sure the legislative leadership is well aware of what our proposals are, and they have had an opportunity to weigh in on that. So I don't know if that addresses your question, Jesse.
Yeah, that does. That's helpful.
Okay. So yes, I think there are funds out there but it will have to go through a legislative appropriations process.
Yeah. Okay. The other thing, sorry, and I see Steph has her hand up. This is more for an agenda item in the future, because I don't think this is something, well, Nate, you kind of alluded that we're all pretty familiar with the consensus process. And I just started to think that I'm not sure we are. It's been a while since we really covered it, talked about what it entails. We all talk about consensus. These numbers came out of consensus, but I could just speak for myself, having been involved in this, for years. I think there's still questions about what happens in consensus and how we reach those numbers that I think could be really informative. So, maybe that's an agenda item that we could cover in the future, just to provide a little bit more context there.
Yeah, we'd be happy to go through it. Let's see, Eric, how many lines are on the spreadsheet now? About 180.
Yeah,
individual
something in that
lines.
neighborhood. Yeah.
I mean, it'll be, I would just suggest that before we go through that everyone, like have a little caffeine or eat your Wheaties because it's quite an arduous process. But I think we can talk conceptually about, what the intent of it is and what basic things are taken into consideration. And I think the most important thing about consensus is it really is a process that is intended to make sure that the governor's office, the legislative fiscal analyst, and the division all agree about the major levers that are impacting the Medicaid program, and whether that be caseload growth or other major, things that are happening, because that's what it's intended to do. So all of those issues and those discussions are resolved before we get into the appropriations process. And it's not like it was before where everyone was disagreeing and fighting through the public process. So, even just agreeing on how many people do we think are going to be in the Medicaid program going forward in all of these different categories that all have different costs associated with them, even just coming to that agreement is huge. So, but we could, I think, they could put it on the future agenda and really just go through the process. It might be interesting. So.
So
Yeah,
your popcorn. Oh, go ahead, Steph.
No, I was going to say that was actually part of what my question was too, is I was just going to ask more about that. And I'm just curious, like how much influence, so I hear that like legislative leadership, the governor's office and the division are involved. And I'm just curious, like, is industry also involved in those conversations, or what kind of power do they have? Because, because I do think that there are reports that have come out this week about, just the growth in the cost of healthcare during the pandemic, even though utilization has gone down. And there's reports that Medicaid plans in particular are going to have increased profit margins. And I know we've had like previous conversations about some of this, but so I guess I'm just curious, like, what is that process like in terms of like who all has an influence in that conversation?
Yeah, I would say, and I don't want to steal all the thunder for, regarding future consensus discussions, but, certainly we reach out to our contractors who are basically responsible to deliver services for our members, to find out if they are aware of any major program issues. So for instance, one of the things that definitely impacts Medicaid spending are these blockbuster high cost drugs. And sometimes we will see them in the fee-for-service data, but sometimes we don't necessarily, because the majority of our folks are enrolled in managed care. So yes, well, they will let us know, like, this drug is starting to hit us. And sometimes these drugs are, there's one out there that is a couple $1 million. And it is huge because it basically it cures a very significant issue. But so we seek their input on things like that. Any other influence that what our managed care plans get right now, what our ACOs get, is really driven by state statute. And so, we go through that process. Typically, what happens is consensus builds in a standard 2% increase for the accountable care organizations. And this year, because of statute, also built in a similar increase for our behavioral health services and our plans. But oftentimes, at the rate of inflation right now, the rate of inflation on the medical side is higher than 2%. So if there's to be any additional appropriations in that area, it would be, the plans that would have to work directly with legislators on that. But that doesn't happen through the consensus process.
Okay, thank you. And then one last question I have was just, you said that you did have a lot of the needs met in the budget. Were there things that y'all asked for that you didn't get, or I don't know if you're allowed to tell us that. I'm just curious.
So now that the governor's budget is there, is published, that is what we speak to. So, I think we all know there's always unmet needs in the community, right, and in programs. But I think at this point we were pretty excited that I can't speak for human services, but at least on the health side, we were treated very well in the governor's budget.
Yeah, I think just to echo that, obviously, I'm sure that every year there's things that aren't funded. Overall, I think as a Department of Health and Human Services, we're very pleased with the governor's priority on these emphasis points that impact so many Utahns. So definitely, thanks to our partners at GOPB and for their thoughtful, discussions we had in going through this. It was a good year.
Yeah, agreed. Okay, and then Nate, do you want to maybe just talk a little bit about how the social services appropriations process is going to work, just to inform the group? Again, this is all new to all of us, but in the past, the way that the appropriations meetings have been scheduled have been very much by department and then by division. And I think for those of us that have been around for a while, we kind of know the routine, but this year it's going to be a little different. So maybe if you could just touch on that.
Yeah, so I think to some extent we're right in the middle of working through this. As we know, the first 3 weeks are the appropriation subcommittee meetings that we're working with the legislative fiscal analysts on kind of their agenda and scope. As we've come together as a consolidated agency, they're looking at changing their agenda format around kind of our line item and operational, organizational structure. And so, they've sent us an agenda with kind of their attempt to put these items together. And so we are now in the process of working with them for, like, example, operations, the area that I'll be working in, making sure that we have the divisions and offices under that operations area represented on a specific day or days, right? And we do likewise for the healthcare administration area that has, the integrated healthcare, which is, Medicaid, behavioral health, our long-term services and supports, making sure that we have similar type organizational structures reporting on similar days, just to try to be consistent with where we're at. So we're currently in the process of talking with the LFA and working with them on how to structure those agendas and daily meetings around kind of those two different items. I think this may or may not be new to some of you, but in working with the legislative fiscal analysts, historically between the Department of Health and the Department of Human Services, we had 19 line items, right? And line items are kind of set buckets of money that you can't necessarily transfer between and create some operational silos in how we spend our money. In bringing these two organizations together, Health and Human Services, we're able to reduce those number of line items to 10. Right, which provides us more flexibility, throughout different parts of our department in working with and addressing needs that we have. So, we're excited about that and look forward to the kind of opportunities and challenges specific to Medicaid. Though there is a provision that funds can't be transferred out of Medicaid without prior notification to out of the Medicaid consensus areas without prior notification to the appropriations chair. So there are some additional safeguards around how that Medicaid consensus money is spent and utilized within that new structure as well.
Okay, any questions about that or anything else?
Yeah, can you just remind me, we've talked about this before as a committee, but is any funding going out of the Medicaid restricted account this year, or is this the last year, or is this not happening anymore?
So it does appear, based on the recommendation has been, and maybe Tyler can correct me if I'm wrong, that it looks like they're using about 16 million of general fund that was in the restricted account one time, I believe, to help meet some of the appropriations needs.
So Emma, I think that's all correct, but I think it's the expansion fund, not the restricted.
Oh, excuse me. Did I say that? Oh, you're right. It is
You're good.
Just the extension fund. You're right. Yeah, so that's what's happening.
Okay, thanks. And that was recommended in the budget, in the governor's budget.
Yes, that's my understanding, Eric, correct?
Yeah, that's my understanding as well.
Yeah, okay.
Thanks. Okay.
All right. Well, thanks, everyone.
All right. Thanks, Nate. Appreciate it. Appreciate you for carrying through. There were supposed to be 3 people doing this, and Nate got the whole thing. So
Hey, that's all right. I'm willing to jump in where I can. Hopefully it was useful. Yeah, thank you.
Thanks.
all right. Thanks.
All right, thank you. Well, let's move on. Thanks again. That was a really helpful overview. And let's move on to the Hedis and the CAPS measures report. And Greg Cholm, welcome. And yeah, excited to see the latest.
All right. Thanks, Jesse. Thanks. All right. I'm going to present. Sure, I've got the right one up here.
And Sharon did share these with the list as well, so everybody should have a copy of them.
Okay. All righty. So on an annual basis, we come to the MAC and we just share information related to Hedis and CAPS measures. For those of you who aren't familiar with these, the Hedis measures, and Hedis stands for Healthcare Effectiveness Data and Information Set. So this particular set of measures is used by approximately 90% of US health plans. And as a result of that, it allows both medical providers, practices to furnish information that can then be used across the board to compare plans, compare measures across plans, and to look at how health plans are performing. But it's also used by healthcare providers and systems to both improve care and services to enrollees. So Hedis is managed through the National Committee for Quality Assurance. They are reported every year. There's a whole host of measures that plans are required to report on. However, for this purpose, there's just a subset that we report out for the MAC and that we actually track with our managed care plans. And the other survey tool that we use is called CAPS, which stands for the Consumer Assessment of Health Plans and Systems. And this is a survey performed by a third-party vendor, and it essentially measures the experience from the consumer standpoint with respect to the healthcare that they receive, as well as the plans that they're getting those healthcare services through. The Hedis measures are done in two ways. First, there's just claims-based measures, which look at the direct services that are provided and the feedback from those. But we also have measures that include a clinical review component. And so there's a mixture there with respect to the Hedis measures and how that information is gathered. Hedis measures and the CAPS, what we'll be saying is the information with respect to the care delivery, in this case, the consumer assessments during the last year, 2020. And so with that, it's good to sort of note that 2020 was the hardcore hit for the pandemic. And there's going to be several factors that I think play into just the measures themselves, the services that could be delivered, and then also just getting the data and the information out that's required for plans to essentially report out for these particular measures, particularly Hedis measures. So I'm going to scroll through just a couple highlights. We have 16 Hedis measures. The ACOs track these, and these are mapped to the ACO plans. One thing to note is with our Utah Medicaid Integrated Care Plans that started January 1st, 2020, we will be also seeing the first year reporting for those particular plans. And we have 8 overlapping measures between the ACO physical health plans and the UMIC integrated plans. And then there's 5 specific measures that are just for the UMIC plans because, as noted, the UMIC plans combine both physical and behavioral health services, whereas the ACO plans are just covering the physical health pieces.
And Greg, if I could just maybe
You bet.
chime in for a minute. So there are a lot more than 16 measures that most
Oh, yeah.
plans report on, but for some of you folks who have been involved since the beginning of the ACOs, there was a fairly robust process that we used when the ACOs were established that involved other stakeholders and advocacy groups and others to try to identify what are the areas of HEDIS measures that we most want to focus on, and we broke it down by different populations, essentially looking at HEDIS measures for pregnant women, for children, for individuals, I believe, with disabilities, and just for adults in general. So these are the ones that we focus on, and one of the things that we have been discussing recently is, should we, going forward, take a look at those measures and maybe revisit that and decide, are these really the most important ones to look at or not? So just know there's a lot more than 16 HEDIS measures that plans typically report on, but these are the ones that we share every year because the plans are contractually required to report on these specific ones, at least to Medicaid.
Yep. All right. So we'll just walk through and people can take a look at these particular measures. Again, one thing to note is that the UMIC integrated plans are only serving currently the Medicaid adult expansion population. And again, so it will be adults, and in those cases, we did not have them report out on like childhood measures because kids aren't enrolled with the UMIC plans. So, and just to note, like some of the key factors that I would say were in effect for 2020 were, number one, we had clinics and providers that just weren't open for several months. We also had just even hospitals or more urgent care, putting restrictions on, who should come to those types of facilities. We also had just general concerns about people going out to get services and just COVID exposure. I mean, there's a lot going on in 2020. And some of those things I think play into, in some cases, where we see some decreases in these measures. And again, well child visits, preventative care, immunizations, those types of things. I think in a lot of cases, we saw some decreases in those. So this is childhood immunizations, well child visits. So NCQA actually made an adjustment to this measure. So this is the first reporting year. They used to have a combined measure, and what they did was they split it up to include 6 or more well child visits within the first 15 months, and then follow up to that 2 or more well child visits between 15 and 30 months. So these here are the first report outs for those 2 changes. Immunizations for adolescents. Childhood and adolescent BMI assessments. Breast cancer screening. And what we'll see here is, like, when we're looking at these graphs, this blue line is the national average. And so you'll see the national average just trends across the last 3 reporting years. This one is where we'll see, like right below here, we put some bar graphs in here just comparing the measures between the ACO plans and the UMIC plans. One thing we'll note as we're going through this is you're going to see several measures where potentially there's nothing reported. And that can happen for a few reasons. In some cases, measures, and when we're talking about the UMIC plans, which are just in their first reporting year, some of these measures actually look at multiple years of information to come up with the assessment. So in this case, for breast cancer screening, as part of that measure, there's actually a 2-year window that's reviewed for this particular measure. And so that's why you'll see, like, for example, Healthy You doesn't have a UMIC reported measure in this particular column. And the other thing that can happen is that, particularly with the UMIC plans, as I said, UMIC plans are just the adult expansion population. And so just the number of enrollees in each plan is quite a bit smaller than what you see in the ACO plans. As a result of that, sometimes there's actually not enough, or I should say there's not a large enough sample size to actually produce what would be a statistically valid measure. So you don't have a large enough sample to actually create a measure for that. And we'll see some of those as we move through. This is cervical cancer screening, UMIC ACO comparison. As you're looking at these graphs, just so you know, the hashed bars are the UMIC plans, the solid bars are the ACOs. Postpartum care.
And just to be clear, so the blue line, if the bars are below the blue line, that means they are below national average. Is that right?
That's correct. Yep.
Okay, just want to, so 2021 not looking good for postpartum care in most places. Is that inaccurate for here in Utah?
That's, well, yeah. I'm just sort of falling back to my caveat. Like 2020 was an unprecedented year on the healthcare system and healthcare delivery. So, you know, as I look at these, I just sort of have that in the back of my mind, like what impacts, you know, did we have with respect to people's seeking care, and in this case, follow-up care and those types of things. So. Prenatal care.
And Stephanie, do you have a question?
Go ahead, Stephanie.
I do. I hear all of that, and I guess I just want to provide an alternative perspective of the fact that there are contractual obligations for that plans and provider, like the industry enters into contractual obligations on this, and the promise of the triple aim was like what we were all told. And so I understand that this has been a really, really hard time, but I also think it's important that we don't lose sight of the fact that, like, it is a really large industry and that there should be ways in which they're still able to provide care regardless of, like, the difficulties of the year, and that, like, the lack of connection to Medicaid members is contributing to other issues like low vaccination rates. So I hear all of that, and I also just I don't want us to just pretend like we can't expect that, you know, businesses that enter into contracts are still required to, like, fulfill their contractual obligations. So it's been a hard year, but it's also been a really hard year on people in poverty, which is Medicaid members and people with disabilities. And I just, like, really hard, like more death, more disease, more severity, more poverty, isolation. And, like, we do need to push the healthcare system to, like, do better because we're letting people down. And that's just, so anyway, I hear all of that, and I just want to say that it's not an excuse for them to not do what they're supposed to do.
Do you mind if I jump in?
Oh, well, let me just jump in.
Sure, go ahead, Emma.
So, and I agree, Stephanie, but I do think it's a bigger issue than just the plans. The plans don't really, I mean, the plans can help influence and should be influencing, you know, how services are provided, and but it's also physicians, and it's also hospitals, and it's also clinics. It's a more of a whole community response, right? So I do think that we absolutely can improve, but sometimes it's hard when there's a shortage of providers. It's hard for anybody to get services sometimes, not just our Medicaid members.
Yeah,
And again,
that's,
not an excuse, it's just a reality, unfortunately, that we're all dealing with. But I think when we're out of COVID, I think we need to see if these measures go up. I mean, this is the challenge now. You know, it's like we need to make these things go up.
and I agree with that, but I guess I do want to just say, when I say businesses, I mean like all of them, because I totally agree,
Okay.
it's a whole industry, but it is like, it is hard because like when we fight for people to access Medicaid, a part of that is because we have these expectations of what access and coverage is going to be, and we know that data says that access and coverage aren't, you know, adequate to securing health outcomes, but we do hope that people getting on Medicaid means that they're going to be able to have a relationship with healthcare providers that is trusted and good, and that basic important primary care is going to be prioritized so that we are decreasing some of those conditions down the road. And so I guess like even and in a pandemic, it should be more important than ever that we expect that people who serve truly marginalized community members really have to, like, they need to, like, that's the whole point for them to have established relationships with like for the system to work. Like the whole point of making sure it works during non-pandemic years is so that during a crisis, we can really make sure that the most vulnerable people have better connections into the system. And so I guess I just worry about the ways in which it feels like as a society and the narrative over the last while just feels like we are making excuses, but I worry about where the consequences will fall, because they may not fall on the plans, but they do fall on Medicaid members, and they fall on communities that get hit really hard because we aren't we're not doing enough to secure those relationships with them, or to address their needs, or to like make sure that we're like whatever, you know, communication or whatever it is. Like if we had it really good during non-pandemic years, then during the pandemic, think about how great that would have been, and we wouldn't see some of the other data points during COVID that we have. So anyway, I just don't want us to lose sight of like the consequences fall. It's just they may not fall on the plans, but or the providers or the, you know, whatever, but they definitely fall on the people that are hit the most. And that, you know, and I just feel like I can't not say that. But anyway, thank you.
Yeah, and we appreciate that. So Brian, sorry, I didn't mean to cut you off, but
no, and we can keep going through this, but I do want to. I do want to address Stephanie's issues. She's kind of, I mean, she mentioned a lot about contractual obligations and excuses and not getting clients in. And that's a little vague. And what I would ask for anyone in the MAC, so I represent, I'm the ACO representative of the MAC. And so I need to represent all ACOs, not just the one that I work for. So I want to be very, I want to be neutral to all of the the ACOs. But what I would ask, if you really have a concern about the quality of care, or if clients aren't getting the care that they need, please contact any one of the ACOs. We would be so happy to meet with you and show you specifics on what we're doing to help these individuals. I mean, I don't think, and I don't think you would think this, anyone on the MAC, but would you think that doctors are out there colluding to say, hey, you know what, this individual has X ACO on their Medicaid card, so we're not going to provide them with the best quality of care. We're going to make sure that the other ACO gets a better quality of care. That's not happening out there. The issue, what Greg and Emma brought up, is it's access to the data. It's access to the medical records. That's the issue that we're trying to deal with. That's why we need to come up with a better alternative to this.
I think
Does
it's
that
a
make sense?
combination. I think it's a combination. There has been a struggle accessing medical records, and that's also a reflection of just the fact that healthcare systems are so busy that they're basically saying, we don't have time to send plans, we don't have time to send you the medical records. And sometimes that's the only place where the data is. I do think Stephanie has a point that I think just as a whole community, we need to do a better job of connecting individuals with primary care. And I think that's one of the things that I heard Stephanie say. So I think it's a combination of things. And I do appreciate the ACO's willingness to meet. I also obviously will extend from the state if anyone has any specific concerns to share it with us too. And we'll engage the ACOs, to sit down and go through it. But these numbers are a reflection of a couple of things. And I do think some of those are the realities, but I'm also very sensitive to what Stephanie is saying as well, is this is our focus, is this, this group of folks. And it has been hard. We do have a shortage of providers. I don't know if anybody, in this meeting's ever tried to access a specialist, but it doesn't matter who you are. It can take weeks or months to get an appointment. And so I think it's just such a combination of different factors that are influencing this reporting that I don't want to give up on it though.
Sure. And that's fine. But I do want to represent from the ACOs that we as a collective group have spent hundreds of thousands of dollars on increasing awareness to our members to get in and to get primary care services and immunizations, whether it's through phone calls, whether it's through mailers. And what we're hearing is the people are afraid to go into the doctor's office for fear of getting COVID. So guess what? Our telehealth visits are up substantially over this last year. But some of these services or the Hedis measures are in-person type things. You can't get an immunization over the phone or over the computer. So this is why. But the ACOs are doing everything they can to help get individuals established with primary care, to get them immunized, to get them vaccinated for COVID. All of these things, we're spending thousands and thousands of dollars to do it, and people are afraid to go in. That's the issue.
And I do think that is a reality during this period, is people have been afraid to go in and seek services, just across the board, no matter who they are. So
can I just add, I put this in the chat, but Greg, one thing that does pop out at me, we're talking about the pandemic, but the numbers for 2019 for some of these things are not any better. And
right.
I look very closely at the prenatal, the postpartum, and the children's metrics and the maternal metrics, and they weren't good before the pandemic. So I think, this is not a surprise that
right.
But I am extremely concerned because yes, we can say that 2020 or in a unique period now, but these are. Looking at the 2019 rates, I mean, that is incredibly concerning. Our level of prenatal care for some of our most vulnerable populations in our state to be, less than, around 60%. That's way too low. And I think we all know that. And so I guess my question is, Emma, you've been incredibly committed in the, department and others to looking at this. And I'm kind of putting you on the spot, but will that continue with this new Medicaid director? Because I know you've also made a commitment to, specifically begin to look at these in the quality strategy and the contracts. And we've had some really, really terrific conversations about that. But will that commitment continue. Thanks, because Lynette has been part of some conversations where we really are taking a deep dive into these metrics and seeing what we can do and what can be done, because we know that they haven't been great across the board for a while, and that's incredibly concerning.
No, I think there is an ongoing commitment, Jesse, no matter what, because this is an issue that we, especially for kids and wellness checkups and immunizations, and we've had this discussion before, and again, not excuses. I just don't know why the reality is this, that every state in the country is basically reporting the same thing. They've seen a significant decrease. And so how do we address that? You know, the whole prenatal care issue, some of this becomes very complicated because sometimes women don't even come to Medicaid until they're in their third trimester or about to deliver, literally. Or sometimes they'll deliver and then they'll apply for Medicaid. And so, and yet they're still in that, you know, they're still in the denominator. So these issues become complicated because we may have never had an opportunity to get them prenatal care. They didn't seek prenatal care. They didn't even seek Medicaid until the very last minute. So there are some weird nuances about some of this data. But I think it's important that we delve into it. And I think, you know, I will certainly be relaying this to Jack. My impression is that he's all over this, this idea of transparency and accountability. And I know, you know, Tanya and Eric and others, we want to see all these numbers go up, but I think we also need to understand them too, and compare them also against what's happening in the general population. I think would be interesting. And Lynette, did you have a comment or a question?
Yeah, Emma, you covered a lot of what I was going to say, but with the prenatal, it is an issue that these women don't always sign up for Medicaid timely. They may find out from a primary care physician or even from an ER visit that they're pregnant. And then by the time they've signed up for Medicare or Medicaid and gone through the processing, there's usually about a 30 to 60 day lag before they're actually assigned to a health plan. And then we're outside of the range for the early prenatal care. But again, it's a data issue, trying to find out where they were seen before they became a member, and you know, making sure that they get directed to appropriate care. It's certainly an effort that we're making.
Jesse, it may come down to maybe a legislative order for hospitals and providers to help with getting the data more timely and effectively. We're just throwing it out there.
Thanks. And I see, and also thank you, Lynette. And I want to just acknowledge that Lynette has also been you've been really great in working to address this, or the pediatric measures. So thank you so much for that. Michael, you have your hand raised.
Yeah, sorry to interject, but as I listen to this, it sounds like there are a couple things and questions that come to mind. One would be if the big part of the issue is getting women in early or earlier, certainly some opportunities there with the public health side of the Department of Health, and hopefully with the consolidation of trying to address some of those issues in terms of getting people into Medicaid earlier, so that the prenatal care can be provided, as well as public service now, you know, an increase in outreach, that sort of thing. So the question is, you know, are there some opportunities there that you're looking at with consolidation, as well as working more closely with local and state health department, public health side of the fence, or other initiatives that the department can be working with the plans to address the problem?
Yeah, I would say potentially, Michael. I mean, we haven't had that discussion yet about involving public health, but I think that's a good suggestion, and we definitely should look at that. You know, but at the end of the day, I mean, fortunately or unfortunately, it is somebody's choice as to whether or not they want to come in and seek Medicaid. Even when we've made people aware of the program, and I know you're aware of this, typically people don't seek this program in many ways unless they have a medical need. And sometimes, you know, pregnant women don't really relate to that until the last minute for whatever reason. So I do think your suggestion is a good one, though.
And I'll just add, we've been talking a lot about this metric, but I think the conversation should, this has been one area to dive into, but we're looking at things that are bigger than just this one metric. I mean, Michael, that was super helpful, but I know as we're scrolling through, we could probably spend just as much time on another metric that's equally, raises flags. What's not? Yeah. So I'll let you keep going, Greg.
Okay. I mean, and I do want to be considerate of the time that's been allotted for this. I know we did present or provide these details to the MAC, and I'm happy to scroll through, the remaining measures. Just so this is imaging for low back pain. Antidepressant medication. And again, in some cases, like I had noted before, sometimes we're dealing with sample sizes that are too small, and so we can't create a valid measure. And so you'll see that some things are not reported. Just this graph here should have been like percentages, not the 0 to 1, if you're looking at that particular graph. Upper respiratory infection. Trended up for the most part. Controlling high blood pressure. A1C testing for diabetes. Diabetic eye exams. Access to preventative ambulatory health services.
So one of the things I think would be helpful, and is that the last HEDIS measure, Greg?
Yeah.
Is there more? Okay.
Yep. Or then we just get into the UMIC specific measures.
Okay.
Yeah.
I was going to comment, in some areas, the plans are actually performing better than the national average. But so I think, we don't want to lose sight of those, and we don't want those to decrease. But I think if we want to have more discussions about strategies around the areas where we're below the national average, maybe focus on some of those areas.
Yeah. Well, and I think to your point that you had mentioned, and one of the things we have been in conversations about is doing a collective performance improvement project with the ACOs, involving stakeholders in that discussion to really look at, why consistently over time, for example, well child visits in Utah tend to lag behind the national average. Like, what are the factors that are going into those? And then sort of identifying things, because there will be things that you can identify maybe that the ACOs have direct leverage over, but then there are some other things, as we were just discussing with respect to prenatal care. And, you start expanding that conversation because you have to, in order to sort of make inroads into a particular area, because it requires, more than just a small subset of folks to try and drive change for a particular issue. So.
Thanks, Greg. And I know, Yeah, that collective look, I think, has been really helpful, and I'm excited to keep continuing that work. And Brian, I don't know if I quite caught what you were saying. I meant to revisit it about the data issues, and I thought you said maybe like it would require an appropriations to change it. I wanted to just check with you about that, because that's something that hasn't come up in the group, but maybe we need to. Well, can you just clarify that?
Yeah, not through appropriations, no. And it's something that, could be a last resort type thing, but if we want to keep going with what Greg and Emma have just recommended, I think we should. But I'd also ask Jesse if you would like to talk with any and all of the ACOs. We have an ACO coalition meeting. If we want to schedule a time to really go through the quality, not so much the data, we can do the data, but really more about the concept and what we're trying to accomplish, and what the ACOs are doing to try and accomplish it. We're happy to have any of the members of the MAC or anyone in general, because we are doing a lot. It's just there are issues. The prenatal thing is different because they don't get on until later in their pregnancy, and we don't have a lot of opportunity to help them. But aside from that, we are reaching out, and like I said, a lot of this stuff is happening now via virtual telehealth. But some of those things you can't do virtually, like immunizations, those kind of things. They're just yeah. So there's Greg and Emma have done a great job of articulating what the issues are. But I would welcome anyone that wants to get a little more educated on the specifics of this to do it.
Okay, thanks, Brian. Greg, did you want to just briefly go over the CAPS portion of this report?
And we are over time. Sorry, Greg, you can do a rapid CAPS if you want.
A rapid CAPS? Okay.
Rapid CAP of CAPS, please.
Right. So again, you'll see there's child and adult surveys, and well, the kids aren't necessarily doing the surveys. It's a guardian or parent that's essentially speaking for kids' care. But so this is customer service, how well doctors communicate, getting care quickly, getting needed care, on the adult side, customer service, how well doctors communicate, getting care quickly, and getting needed care.
So I would just invite folks to, this has been disseminated to the MAC and the list of individuals who usually attend the MAC. I would suggest you look at the report, and if you have additional questions, or Jesse, if in the executive group that if the executive committee wants to put any of these on the MAC agenda for further discussion, or maybe, as you said, the other committee that Lynette and Greg and others have been participating in, try to drill down through some of this in that committee, I think would be great too. But I think it's a lot of information that people probably need a little bit of time to sort of ponder on, and then have some further discussion about.
Okay. Yeah, in the interest of time, yeah, thank you, Emma, for that. And Greg, sorry that we have to cut you short, but I totally agree.
No, it's fine. There's a lot of information in here.
The other thing, Jesse, I was going to recommend, and this is, however you want to proceed on the agenda, but we also, there was a question, I think, some of the questions that have come up in terms of managed care update. I think this is just the whole quality area, and something that we want to definitely delve deeper into. The other things that we would typically report on is, are we planning on doing any expansion of managed care? Right now, I will tell you quite honestly, with everything else going on, we've had some discussions about should we expand the integrated contracts, the integrated approach to the balance of our mandatory ACO counties. We have agreed with the local authorities, that local mental health and substance abuse authorities, that we would not do that without first sitting down with each of them and meeting with them and talking about the unique issues in their areas and trying to address that. And with everything else on everyone's plate, we have not gone any further on that at this point. Other than that, I will just mention that the dental managed care plans, their contracts actually come to their end of their 5-year period in August of 2023. So next year, the division and the Bureau of Managed Healthcare will actually be putting together another request for proposal to procure dental managed care plans for Medicaid, because that's what we have to do every 5 years. And in this case, this actually is driven by statute. The statute requires that we go out and do a procurement to basically contract with dental managed care plans. So that's the other thing that will be happening in the relatively near future. Beyond that, what we had thought about doing was maybe going over some of the federal requirements, not only of Medicaid managed care plans, but also of the state's obligations in terms of oversight. But I honestly am not sure we're going to have time to do that today. So we can either have Eric Grant do that at this point, or maybe hold that for the next meeting, whatever you'd like to do.
I think I would like to give enough time for that conversation. So let's hold off until January, if that's okay with you, Eric, because we do have do we have a January meeting?
There should be one, yeah.
Okay, because I know during the session, things get a little off, but Eric, if that's okay with you, that would be my preference, to just make sure that we aren't rushing that conversation, but we can actually spend a little bit more time with it.
You bet. I was looking at what I've written up, and I was thinking, how am I going to cram that into 10 minutes? So that's great.
Okay. Great. Thank you for being willing to present on that, though. So we'll just move you to January. Thanks. Okay. With that, then let's move over to Jeff and Morris to do an update on enrollment expansion, also on the unwinding.
Good afternoon, everybody. This is Jeff Nelson with Medicaid Eligibility at the Department of Health and soon Human Services. Today we opted to not show the chart. I will give you a very quick overview that nothing much has changed. We continue to keep cases open. We've been doing that now for quite some time, over 20 months, and trying to make sure that holds true. We have still increased in the adult population and in the children population. So that does continue, and it continues to drive the line that it has all of this time. So it is interesting to me that we are adding still about that 3,000 children each, or 2,000 to 3,000 children each in every month. And that's impressive during this time. But I know we're meant to talk really about the unwinding and what happens once the PHE is to end. And so we're certainly happy to take questions and comments on either issue here as we go or at the end. As far as the unwinding goes, we do continue to pull our plan together. To be very clear, the public health emergency is not over yet. We are told we will be given a 60-day notification of when that is to occur. That has not yet happened. And so we do not think that we have anything at least until the end of February at this point in time. So that's good news that we can continue on our merry way for the moment, and gives us a little bit more time to plan. I think a couple things that are significant that have occurred since the last time we met. We did meet with the health plans, and that was a very productive meeting, I felt, to talk about how we may communicate as this unwinding occurs, as we review the Medicaid eligibility for each of the members. And it's going to be, I think, very helpful to communicate well with them. I think it was a little bit eye-opening for them and for us both, really, to understand better what they need and what they would like to see. For example, we're proposing to give them a list of those people that are leaving the program based on whether they're actually not eligible, which means that they're headed to the exchange, versus if they've not completed the paperwork portion of what we do. And I think that was an interesting moment for us as we discussed that. So we do continue to pull all those details together and hope to have an abbreviated version to share with everybody as we get a little bit closer to that actual unwinding. And I think I saw Emma make a comment on this.
Yeah,
pause.
sorry, Jeff.
Okay.
I was going to say, just to clarify, so what the plans have asked for is a list of their enrollees who are going to be no longer eligible for Medicaid because they really don't qualify for the program, but could be eligible for their marketplace plan, because there is a great benefit to having continuity of care, especially with provider networks. If they are not going to be on Medicaid, then perhaps they could enroll in that entity's marketplace plan and at least still have access to the providers that they've already been seeing. So I just wanted to clarify that.
And another area that I would mention that we focused on over the last little bit is what might happen with some of the DCFS or JJS, the Juvenile Justice System or Division of Children and Families. We're trying to work through what happens with the foster care children as we move out of the PHE. And we've made some internal decisions or had at least those discussions of where they might be served best. And for example, DHS right now does not have the capability to really look at another program for them. And the mail that goes to those folks really returns back to DHS. So any mail that you send on a case that's with a foster care child goes straight to the DHS worker. So in the world of trying to make sure we keep continuity, it seems to make sense that we start to transition some of those cases over to DWS to keep open. That way, when the time comes, we're able to both notify a little bit better, and DWS has the ability to look for the next program for those children. So we've had some very good discussions down to that level of detail of what might happen with different groups. And that's just a couple of examples of that. Again, we do hope to have a plan that we can share with you guys very shortly, including a communication plan, et cetera. So we do continue to work on it in the background. It is not a dead issue for us. It's a live issue. It's one that we need to continue to work at and get better at, but we're not there yet. The message should be that right now, Medicaid remains open. We continue to keep those cases open, and we'll do so until such time that we're told. And that's working out pretty well so far. I did promise to give Maurice a little bit of time today if there's any DWS updates as well.
Thanks, Jeff. Our updates are going to be somewhat similar. On our end, the event that has been happening for a little while now is the Ffm Open Enrollment. Initially, that was a little bit of a heavier start with larger number of individuals being assigned to us, but it has leveled out to about a 1,300 a week pace in terms of referrals that we're getting every week. Able to handle the workload, this goes on for a little bit longer. We are not having any issues with transfers or receiving or processing applications. To the topic of PHE, as Jeff has mentioned, we continue to collaborate together to finalize our plans. On the other end, we're also preparing for the operational impacts that we're going to have from that, identifying resources to help us with that, making sure that we communicate with our systems to kind of inform them of what changes coming our way, and to be prepared to the level that we absolutely can be prepared when the notification actually comes and we have to start deliver on this. So as we speak, we're actually interviewing new staff. We're doing this in 3 locations. We should be making some offers here shortly. And the start date for some of the new folks, we're expecting to hire somewhere in the neighborhood of 50 to help us with the PHE the first of the new year. That is it. Thank you, Jeff.
You bet. And I forgot to mention, I'll do that now. As of the December figures, which is really the November data, we have 69,003 cases that we're holding open, which amounts to 122,742 of individuals. So over 122,000 individuals that are being artificially kept open, whether that's they're actually truly not eligible or more likely it's that the paperwork has not been completed and are at risk of closure as we go through the reviewing process once this unwinding occurs. So that number is up slightly from last month. We'll turn the time back to you unless there are any questions.
I have a question. Actually, I have 2 questions. One, are you aware, so there's a certain amount of enhanced funding that would come as the unwinding starts. And have you heard is there any reason you think that Utah would not participate in the, that sort of phased unwinding with the enhanced match versus just, not accepting that enhanced match?
So Jesse, are you referring to what's in the, and I'm going to lose the name of the bill again.
Bill back better.
Bill back better. I don't know why that just can't stick in my brain, but okay. Is that what you're referring to? Is
Yeah.
That phase down? So, I don't know that we would not take advantage of that. I think there's some real questions as to whether or not that bill is even going to go forward. So right now we're just assuming it isn't until we see some indication that it's moving. But yeah, I think, we haven't had any in-depth conversation about it, but, our assumption is if it did get passed, that we would follow basically what that bill is providing. But we'd have to see what we haven't done any analysis of what the financial implications of that really is, right? And that would not be just our decision. That's going to be a decision of the governor's office, and probably the legislative fiscal analysts will weigh in as well, because at some point the amount of the enhanced funding and the cost to the state is going to tip the balance in the wrong direction.
Right. Okay, that's helpful. I just didn't know if there had been any kind of preliminary discussions about that around that topic.
Yeah, we haven't. One of the things that we have talked about so far is, even just without the Build Back Better bill, is just what is the fiscal impact of, continuing, or if it didn't basically pass, of the 6.2% enhanced funding suddenly ending, but still having 12 months of having to, time to unwind these cases, because it's certainly 12 months worth of work. And our concern and focus has been more on that more immediate cliff of cost to the state. And we still haven't done that whole thorough analysis yet either. So.
Yeah. And actually, Leah has a question in the chat. Is it possible to get a list of clients who haven't completed their review in the past 3 to 12 months who would need to do a review or otherwise close as well? And she was hoping to get that by plan.
Yeah, Leah, we've had these discussions before, and we'll take that one offline and have some more discussion about that. I think that is part of what we've talked about, is not just the individuals that we know for sure who are closing, which I think is a more recent request, but trying to identify those individuals who are at risk of closing just because they have not completed any paperwork. So let us take that one offline, and we'll work directly with the ACOs on that.
Okay.
Thanks, Emma.
Okay, one other question. Clearly, it will take time to go through all the cases once the PHE ends. Has there been any discussion about whether cases will be assessed an overpayment notice?
There is no, I thought, and Jeff, correct me if I'm wrong, I thought there were specific provisions, unless it was a matter of fraud, which we are not aware of that at this point, that there are no overpayment provisions on these cases. Is that correct?
Yes, that is correct. There is not any overpayment. It's possible, as we talk about this, if the PHE, for example, were to end at the end of February, we would have 12 months or till February of 2023. Someone's going to be held open all that time, and it's not their fault. It's just the time that we're able to get to them. Therefore, there is no overpayment.
Okay. Great. Thank you. And
Good
thanks
question.
for these updates. This is really, really helpful to have the standing part of the agenda item. And I know these the numbers like that you were just sharing, Jeff, I wonder as we move forward if there's a way to maybe start including them in the enrollment trends or something like that, or in the trend report, so that we can be keeping more regular tasks. I'm furiously trying to write down, even though I know things are going to change quickly. So, but I wonder if there's maybe a way we could explore that, and we could even look at that next meeting if there might be some potential there.
That sounds good.
Okay, great. But yeah, thank you both. Thank you, Mara, so much, and good luck with the hires. Okay, Emma.
Yeah, I'll be really brief, since this will be my last
I
director's
know.
report.
I was about to say that. Your last director's report.
Yes, it will be. So, you know, just a brief update on the consolidation. So this past week, we've actually been moving from what we call phase 2, which was really focusing on all of the elements that needed to go into the transition report that was submitted on December 1st to the governor's office and the legislature, to now what executive leadership is calling phase 3, which is now essentially reconfiguring the executive steering committee, which is going to be driving the more operational implementation of the new department. And then the steering committees themselves will take on basically an organizational structure that looks like the divisions and offices that are now set out as part of the new department. So the executive steering committee will now be reconfigured to be Tracy and her deputy directors, and the assistant deputies will now take over. And all of the focus right now really is on the you know, nitty gritty. What do we need to do? Who do we need to move where? How do we change the signs on the buildings? I mean, that kind of thing. And that's what they'll be doing going forward. And Tracy has also set out a preliminary recommendation in terms of a phased implementation. So which parts of the organization, starting after the first of the year, because we can't wait till July 1 to start pulling groups together in terms of their actual daily operations, their organizational structure, and even their physical location. So some of that is still under discussion, but we're really down to the nuts and bolts at this point. The other thing that I think may have been referred to earlier, so originally, you know, we've spent a lot of time working on identifying the statutory changes that need to be made, and that is a huge undertaking. It is about, you know, 1,600 pages of code that's just Health and Human Services. And then if you look at references to Health and Human Services code, it's spread throughout all of state law. I mean, it was amazing to me where it all shows up. So rather than doing it in one large bill, the recommendation from the sponsor and the Legislative Research and General Counsel is to chunk it up into pieces. So this upcoming session, put enough in the bill to reflect the new organizational structure of the department and any of those areas that need to be addressed to make sure that they can legally operate, and then perhaps the next session do the next phase of combining statute. You know, they would have some, I guess, language in the first bill that would say things, I'm assuming, say things like, you know, where you see health or you see human services, it means Health and Human Services. But just to provide that statutory framework to get started, because there is some risk if we try to do this too fast, we may make errors, and there are, you know, just some concerns about moving too quickly without having the time to do this thoughtfully. And the other thing that we've noticed is that there are provisions, and this is more so on the health side than in the human services side, that are health related, but they're not specifically, or in the Department of Health statute, but they're nothing that the Department of Health has responsibility for. They're more just broader statutes regarding healthcare. And there has been some discussion about should those all be put together in a separate area of the code, because it's nothing that the health department itself really has responsibility or authority to do anything about. So a lot of different moving pieces. So just so you know, when you see the bill moving forward, it will likely not be the 1,600-page bill that's coming out this session. And I don't know if anybody else who's participating in the call wants to comment on that, but those are some of the other discussions that we've had recently. So those are probably the biggest updates on consolidation at this point. And then, of course, yes. Oh, hi, Nate.
Hello, sorry, I dropped in.
Okay.
Just talking about the language in the bill, one of the other things that we found that is tricky related to that, there are sections of code that say this applies across the department. So here's this provision, and it also applies to the other pieces of the department. If you just simply merge that language into a DHHS code section, that then means those provisions now apply across all of the DHS programs, which may or may not have been the intent when the bill was originally written, and may or may not be good for those programs to have those provisions apply broadly like that. So it's, while some of this seems relatively simple, as often as the fact in life, as you get in down to the details, there's a lot of decisions that come up that are actually policy decisions, potentially high impact decisions, down in just individual phrases and sections of code that are sometimes deep into those 1,600 pages. So it's a big task. We're chipping away at it, but there's a lot to do.
Yeah, so essentially, Nate, unless you have any other, I don't know when you jumped on, but I was just talking about moving from phase 2 to phase 3 and getting into the, the real implementation details. So I don't know if there's anything else you want to say about the consolidation.
Just we're continuing to move forward with the staffing of the different positions. You probably saw, you may have already covered the announcement today with the state Medicaid director filling one more of those spots. We're working to identify the next level of leadership related to our assistant division directors and office directors, and we'll hopefully be able to have some information for our teams next week that we'll put out, and hopefully that will just help, as Emma talked about, all these next steps that need to happen to identify for the teams who will be taking the lead roles in those efforts.
Okay, any questions about consolidation? I think everyone's sitting back and going, okay, we'll just watch and see how it goes. So, okay, and then just a couple of other updates on the ARPA funds. During the course of this meeting, we've talked about our spending plan and what we had proposed to CMS, and we've talked a lot in past meetings about the 5% supplementals that we are providing to providers, and we're now, we started with the Hcbs providers, then we, several weeks later, added the behavioral health and school-based providers. And if we're trying to get the word out everywhere we can through associations and through our website and through fax, sort of email blasts, to encourage providers to basically come into our website, fill out a very simple attestation so they can be eligible for these funds. Eric, I can't remember the exact number. I think, we were asked the other day what percentage of providers who could potentially qualify have actually attested to and are receiving these funds. And unfortunately, I think the percentage is kind of low.
It is. It's around, I want to say it was around 25%, but as far as dollars paid out, it's significantly higher. And so what that tells us is those providers that had a bigger significant impact have actually attested.
Right, because it's a lot of money, but not a lot of providers. The other piece of this is, as I mentioned before, we continue to have a difference of opinion about whether or not the ARPA funds can be used for family caregiver compensation. So that issue has been escalated. And then the other provisions of our plan, which would include things like providing infrastructure grants that providers could apply for one-time, expenditures. There's a provision that would allow us to spend some of the money to help provide some services to individuals who are on the waiting list, to essentially kind of help hold them over, I guess, while they're on the waiting list. Our overall spending plan has still not yet been approved by CMS. And I think it's been about maybe a month and a half, 2 months ago when we were on the phone with them, and they said, oh, we should be getting an approval like within a week. And I know Tanya has reached out to CMS, and they're telling us now it's still in clearance. So I don't know what that means, but they have not responded to us. So it's, the responding to us quickly is CMS responding to us quickly, which usually means it takes weeks, if not months, for them to respond. So we still don't have a formal approval on the ARPA funds, but we'll just continue to at least get the supplementals out there and hope to encourage more providers who are eligible to apply for those funds, because the whole idea is to help them, hold on to staff where we have this workforce shortage with a lot of these provider groups. In terms of policies, spas, and rules, again, we've been focused on consolidation and basically getting ready for the legislative session. We have not made a lot of policy changes. Jesse referred to the one on silver diamine fluoride, which I do think is a good step in the right direction for kids. I think our last meeting, we talked about the fact that CMS is requiring the state to submit a couple of spas on non-emergency medical transportation and the requirements to vet drivers and transportation brokers against the federal databases. That one has been submitted. There are some clarifications in terms of third-party liability and how it applies to different types of claims and different services, essentially allowing the states to pretty much pay and then chase essentially services to individuals who are eligible for EPSTT, so basically anyone under the age of 21, but requiring the states to basically apply cost avoidance now to prenatal services, which before states were allowed to just pay it and pursue the insurance company after the fact. So there's some changes that federal law is requiring us to make. We have been in some discussions with OUCH with regards to clarifications that need to be made to our state plan on FQHCs and RHCs, and really just the technical process in terms of how they get reimbursed and how we handle the essentially the settlements that we're required to do under federal law. So we've been engaged with OUCH on that discussion. And really the only rules right now that we're submitting that aren't really 5-year renewals or that fall under the category of the governor's executive order to make sure that our rules are in compliance with the rulemaking manual is the rule that would allow us to basically reimburse physician assistants and nurse practitioners, and particularly where they may serve as in an assistant surgical role. So that rule's going forward, and then just our rule around the supplemental payments that we're making under ARPA to make it clear that it is one time. Providers have to attest, and they have to attest how they're going to use it, but essentially putting that in rulemaking. So those are really some of the highlights that we have been focused on this last part of the year. So I don't know if there are any questions on that. Or Eric or Tanya, if you have anything you want to add. Okay. All right, 3 minutes there.
I have a question. It feels it's very, but do you know if some of the teledentistry or telehealth codes have been opened? Did they go into effect last year?
Yeah, we have been, when you say we don't typically use, we did do teledentistry codes. We did open some of those up under the PHE. On telehealth, generally, we don't require different codes. We just essentially tell providers, just bill the appropriate CPT or Hcbs code as long as you can legitimately provide the service clinically through telehealth. You know, you can bill that code, and we do ask for a certain modifier on the claim so that we know it was done through telehealth. But there really is no specific code necessarily that they have to use for telehealth services.
But the funding for originating site that was allocated, was that ever, sorry, this is getting, I hate to spend like the last minute of your time at the, but there was allocated for originating site. And I don't know if that was ever then it was cut during initial funding cuts. Was that reinstated? Are you aware?
You know what? I would have to go back and look unless anybody else from the division can remember. We could take that one offline, Jesse, and do some research on that. The other thing I think, oh, Tanya, did you have a comment? You're on mute.
Oh, yeah, no, I don't remember entirely what happened either. I do know, Emma, that the funding was very limited to address kind of rural telehealth sites only.
Okay.
And so there was some concern about its broad applicability, which I think is more what, maybe some folks had in mind, but the funding that I think that we received was just for rural.
Okay.
But we'll look into that and report back on that.
Okay. Thanks.
That sounds good. Thank you. And then, of course, we're still going to have to do some additional work since of the interest in telehealth. Right now we're still operating under the public health emergency waiver that we have. And so we will have to look at making an amendment to our existing state plan to allow us to continue telephone only. So we will be working on that. And frankly, it may be as simple as deleting the language that we have in our current state plan, because there's no requirement that we have specific language around telehealth. So we'll be working on that to make sure that we're ready to go when the pandemic's over and the temporary authority expires. So, okay, that's it for me.
Okay. Any other final questions, thoughts? All right. Wow. Well, we're a minute over, but Emma, thank you so much again. We will really, really miss you.
Yeah, thanks everyone.
Yeah, and
I appreciate
everybody. Yeah. So yeah, I know you've got a few more months, but yeah, we will miss you. So. Everybody have a wonderful holiday end of year season, and see you all in 2022. Thanks, everybody.
All right. Thank you. Bye.
Bye.